Hi everybody. My name is Dupree, and I'm really sorry that I cannot be with you over there in lovely Florida. I'm going to give my first talk, which is the fluorescence-guided surgery in acute and chronic ischemia of the small intestine. First of all, I just want to give you a little overview about the application of fluorescence-guided surgery in the acute care setting. Hence, the mesenteric ischemia normally is in an emergency setting. And I found that literature review in Langenbeck's 2 years old from that study group who did a systemic literature review on that question. And what they found is that you have mainly three indications for the use of ICG fluorescence in the acute emergency setting, which is acute cholecystitis, ischemic bowel, and trauma and bleeding. And as you can see on this table, the ischemic bowel question is the most common in the use of ICG fluorescence in emergency cases. As you also can see, it's not only mesenteric ischemia, which is causing ischemic bowel. We have a lot of patients or a lot of cases due to hernias, strangulation, or volvulus or cases like this. It's not the normal mesenteric ischemia due to embolism or chronic disease. What they pointed out in this review is that in 36% over all cases, ICG led to major change in operative strategy. In 20% or up to 20%, ICG led to more conservative approach with preserving bowel, and in 15%, ICG led to more aggressive approaches. So they could show in that retrospective analysis and in a really heterogeneous patient collective with different time of injections and dosages, but they could show a benefit of using ICG in the evaluation of ischemic or post-ischemic bowel and in emergency cases. When you have a briefer look on the literature, you can see another review article which deals with the techniques for the intraoperative evaluation. So do we need ICG fluorescence, or are there other techniques we can use? And they found out that the first of all technique is hands and eyes, and this is still the most important factor, but this highly depends on the experience of the surgeon. So we need an additional technique to further objectify the perfusion status of the tissue. And they reviewed all that different techniques and pointed out that near-infrared imaging seems to be the technique of the future, and we all believe the same. So we have to go further in that topic. This is just a little video from fluorescence imaging in an acute mesenteric ischemia, and probably most of you already know that I prefer the black-white mode, as I described before a lot of times. And you can see that in mesenteric ischemia, you usually have different perfusion patterns next to each other. You have that clearly ischemic part in the middle. You have that like dizzy perfused one on the right, and this really uncertain perfused on the left, where you can also see or only see the little vessels and the rest of the tissue is not well perfused. So how can we get more informations or more objective informations about the real perfusion status of this pattern? I showed you several times before this case report or this several case report study where they tried to find out if ICG fluorescence in mesenteric ischemia can reduce extended bowel resections. And they had all in all 56 patients. And you can see pretty the same result than in the huge review at the beginning, that you had 34% of patients with supplemental informations due to ICG, and in 11% ICG led to major change in operative strategy. We still have the problem that these are small case studies, and all of the studies are, or all of that cases are really different in different patient performance status and different indications. So I'm happy to show you this study, which is from 2022. And this study group assessed the bowel viability in the acute setting in an international multi-center case series. And they had 93 patients, and they divided the whole cohort into that patients who had a change of management due to fluorescence angiography and those who had not. You can see on the table that the patient in the patient factors in each group are pretty the same, with no differences. And what they found out that was that in the group of the fluorescence dependent, or in the fluorescence dependent group, 22 had a more aggressive approach with no reoperation afterwards, and 78% had a less aggressive and more conservative approach with 6 operations afterwards. And the most interesting fact is which one was unplanned in this situation, and this was only 2. So the fluorescence ICG is a really useful tool in the evaluation of mesenteric ischemia or of ischemic bowel. To further investigate, it's useful or it's necessary to have reference values also for normal tissue, but also for mesenteric tissue. And early this year, the Dutch working group publicated this one. They established reference curves for vital tissue using ICG, and they choose different tissues and different organs to evaluate the reference curves, and used the same ICG dosage for bowel and gastric conduit, and a little bit different dosages for other tissues. Hence, the data were collected from other studies. And the most important thing is that they normalized the signal extraction with, in my opinion, the most important fact to have valid curves and valid diagnostic information, and to avoid disturbances due to movement or blood pressure instability. And they did it for each tissue they showed in that curve. And I think this is a right way, and a really important publication for further quantification and evaluation of fluorescence-guided surgery. I showed you this before. We did it a few years ago in a porcine model of mesenteric ischemia. This is how we did it. We just induced the ischemia by clamping the SMA, and we did nearly the same, a little bit different quantification tool, but also we had a normalization to avoid disturbances due to hemodynamic changes and to have a better viability and a better prognostic situation in that study group. And more than all, you can just extract the rest fluorescence or the fluorescence due to former applications and have a better value of ICG. Scheiße. Das war scheiße. Aussagekraft. Was heißt denn Aussagekraft? This is what we did a few years ago, and I already showed it on the conference. We did a porcine model of fluorescence angiography in a mesenteric ischemia. We just clamped the SMI and do different measurements. And I just wanted to show you that we also did a kind of quantification with a normalization tool to avoid disturbances due to hemodynamic changes, and more than that, to reduce the confusion due to prior measurements, leading to more meaningfulness of that evaluation. And as you can see here, this is the same picture from the video before. We can also do it with the real life human videos, just figuring out our quantification measurements, and can see that we have a good perfusion on this bowl and really bad on this one. To just give you an impression that it matters, or the quantification is useful and viable, I want to show you this one. It's nothing to do with bowel, but it's gastric conduit. And we found out by evaluating cases with a gastric tube reconstruction after esophagectomy that by using our quantification tool, we could see that an inhomogeneous fluorescence pattern was a risk factor for occurrence of anastomotic leakage, and the reduction of perfusion up to 32% was not associated with anastomotic leakage. So all that groundwork in the lab can give us more idea or more impressions in the real life in the OR. And just for you, what did we in the last years? We had another setting with sepsis induction, and we did several measurements afterwards just to see how the perfusion is impaired by sepsis, which is a normal state in our emergency cases, and sometimes also after not emergency and elective cases. And we did the analysis of the gastric tube first, the bolus coming next. So I cannot show it to you, but we can also see with that quantification to the impaired perfusion due to sepsis at the different perfusion sites in the gastric tube. So there's a lot of work to do for us. There's a lot of work done, but I'm happy to show you this data, and I'm really sorry that I cannot be with you for a hopefully good discussion afterwards. So conclusion, obviously bowel perfusion is feasible with fluorescence angiography. We can avoid resection, but sometimes we have to extend our resection, and we still need prospective studies, especially to detect the reference values in damaged tissue. Thank you for your attention, and bye-bye. Have fun. See you.